Endoscopic submucosal dissection for early rectal neoplasia, experience from a European center. Introduction. Endoscopic resection has been shown to be effective in reducing the incidence of colorectal cancer, CRC. Endoscopic mucosal resection, EMR, is a well-established and safe technique for the removal of colorectal adenomas. However, in sessile lesions with a diameter exceeding 20 millimeters, also called large nonpedunculated colorectal polyps, LNPCPs, EMR often leads to piecemeal resection. After piecemeal resection, histopathological assessment of R0 resection is near impossible, and the risks of incomplete resection and recurrence are increased. Endoscopic submucosal dissection, ESD, has been developed to overcome this problem and allows en-bloc resection of lesions, regardless of their size. Large studies from Japan have reported high en-bloc resection rates, R0 resection rates of up to 90%, and recurrence rates as low as 2% after ESD for large colorectal lesions. However, ESD is technically difficult and time-consuming, and there is a learning curve for inexperienced endoscopists, especially Western endoscopists. Western data on colorectal ESD are limited, and the role of ESD for colorectal lesions is, at present, not well defined. The balance between the advantages and disadvantages of ESD should be considered, especially for removal of early submucosal invasive cancers, SMICs, as these should be resected en bloc with histopathological confirmation of R0 status to minimize risk of recurrence. For endoscopic resection of benign lesions, EMR might be sufficient, and if recurrence occurs, repeat EMR is effective in most cases. Endoscopic resection of SMICs is accompanied by two major problems. First, prior to resection, the risk that a lesion has submucosal invasion is not always known. Therefore, selection of the best resection method can be difficult. However, sufficient histopathological assessment can only be obtained after resection. Second, endoscopic resection can be judged curative only after fulfillment of the pathological low-risk criteria with a negligible risk for lymph node metastasis, LNM. Low-risk criteria for sessile SMICs have been defined as submucosal invasion of less than 1,000 micrometers, exclusion of poor differentiation, exclusion of lymphovascular invasion, and exclusion of tumor budding. When one of these criteria is not fulfilled, endoscopic resection might be inadequate, and surgical resection with lymph node dissection is recommended. At present, accurate evaluation of these criteria is impossible prior to resection. To date, very little data are available from the Western world regarding the efficacy of colorectal ESD, especially in SMICs. In two small European studies, the curative resection rates for early rectal cancers were 0% and 7.1% during the ESD learning curve. The aim of the following study was to analyze a large number of rectal LNPCPs with regard to their risk of malignancy and to evaluate the potential role of ESD in a European center with a focus on early rectal cancers and going beyond the ESD learning curve. Background and aims. Endoscopic resection is a curative treatment option for large nonpedunculated colorectal polyps, LNPCPs. Endoscopic submucosal dissection, ESD, allows en-bloc resection, but ESD experience is still limited outside Asia. The aim of this study was to evaluate the role of ESD in the treatment of early rectal neoplasia in a European center. Patients and methods. 330 patients referred for endoscopic resection of rectal LNPCPs were included prospectively. Results. ESD was performed for 302 LNPCPs, median diameter 40 millimeters. Submucosal invasive cancer, SMIC, was present in 17.2%. SMIC was associated with Paris type and with surface pattern, 71.4% among non-granular plus mixed surface lesions, 17.9% of lesions with granular surface, and nodule greater than or equal to 10 millimeters. For SMICs, resection rates were en bloc 81.4%, R0 65.1%, and curative 30.2%. Curative resection rate improved from 13.6% to 47.6% over the study period. The reason for 83.3%, 25 of 30, non-curative resections was submucosal invasion exceeding 1,000 micrometers. For benign lesions, the R0 resection increased from 55.2% to 84.8% over the study period. Recurrence rate was 4.8%, bleeding rate 5.2%, and perforation rate 0.8%. All complications managed conservatively. Mean follow-up was 35 months. Conclusion: the majority of rectal LN PCPs are benign lesions. ESD offers high R0 resection and low recurrence rates, but EMR may be appropriate. In lesions with a risk for SMIC, ESD should be offered to achieve R0 resection. Despite high rates of R0 resection, the curative resection rate of ESD for rectal SMIC is less than 50%. Pre-therapeutic lesion selection needs improvement.